Today's topic is neonatal seizure. I am Dr. Nisarga Ramalingegowda, the Oxford Medical College, Bangalore. Neonates are at particular risk for the development of seizure because metabolic, toxic, structural, and infectious diseases are more likely to be manifested during this time than at any other period of life. Coming to the what is seizure? Seizure is or convulsion is a paroxysmal time limited change in motor activity and or behavior that results from abnormal electrical activity in the brain. The neonate brain is not a mature brain. Still it is in a developing stage. Maturation has to take place in terms of organization, myelination, and so many things. And if any seizure or electrical activity occurs in excess, there is going to be a sequel compared to an older child or an adult. It is an emergency situation, seizure, neonatal seizure, and what is required immediate medical care. The morbidity and mortality increases with the seizure in a neonate. In a term baby, the incidence of seizure is 0.5 to 0.8%, and babies less than 1500 grams, the incidence is 5 to 15%. The seizure, most distinctive indicator of neurological problem. Therefore, it is important to recognize, determine the cause, and treat appropriately. Definition I have already given. It is an abnormal paroxysmal stereotypic clinical event that is behavioral, motor, and or autonomic, associated with hypersynchronous neuronal activity. In older children and adults, we do see tonic-clonic type of seizure. Very well organized seizure we see. There is a generalized seizure, partial seizure, and there is a classification for the seizure. That classification does not hold good for neonates. Here, the classification is subtle seizure, focal clonic, multifocal or migratory clonic, tonic, and myoclonic. Each one we will discuss in detail. The seizures, unlike in adults, here they are different. Why? Because it is a growing brain, not fully organized, poor cortical organization, myelination is not complete, then synapses are not established fully. So what happens? The electrical, the conductivity is not as good as older children or adult. In addition, there is predominance of excitatory neurotransmitter receptors, that is glutamate, decreased GABA channel, advanced development of the limbic structure. As a result of all these things, So there is a poor transmission of the electrical activity in the brain. As a result, what happens? So the seizure types are different. It is important to recognize seizure versus non-seizures. Sometimes we mistake non-seizure also seizures. So how to differentiate seizure from a non-seizure? A seizure does not require any stimulus. Paroxysmal, it occurs on its own. But where a non-seizure, something had happened, for example, if there is a cold, the child starts jittering because of the cold. Or all of a sudden, when there is a door sound, when you close the door, when the window fan is slammed against the frame, then what happens? Because of the sound, the myoclonic jerks, you can see the baby. That is a non-seizure. But seizure does not occur with the sound or with the stimulation. And the seizure cannot be restrained. But a pseudo seizure or a non-seizure can be restrained. If the child is shivering because of the cold, you can if you hold the hand, it will stop. But if it is a seizure, it cannot. Autonomic changes. The autonomic changes are associated in the seizure like eye movements, uh, papillary dilatation, micturition and defecation can happen with seizure, but not with the pseudo seizure. Sometimes, there is we may fail to recognize seizures. It is so subtle, or the manifestation is such that, and we may mistake for normal activity or movements of the child, and that is called subtle seizure. We'll discuss that one first. Very subtle, less pronounced. Subtle means also called automatisms and bucco-lingual movements, mainly confined to the face. It is seen both in term and preterm babies. May be difficult to recognize clinically because they are like baby as it is staring, or there may be eye movement like nystagmus or deviation a little, eye deviation, blinking. Just the baby is blinking like. So we must make the baby is blinking. It is a one type of seizure, but we mistake it may be normal blinking. Or the sucking movements, chewing movements, or protruding the tongue repeatedly. And sometimes as if the baby is swimming, the movements are seen in the limbs, paddling or stepping, rowing movements. Look at here. And sometimes it can manifest like an apnea. In a preterm baby, apnea sometimes apnea can occur with a respiratory center not matured. That is not a seizure. The apnea can occur in extremely preterm babies, but a seizure also can manifest like apnea. Please remember this point. Coming to the clonic, it is a rhythmic movements of the body parts that consists of a rapid flexion phase followed by a slower extensor movement. Can be focal or multifocal. Usually seen with birth trauma or hypoxic ischemic encephalopathy. Coming to the tonic seizure. Tonic seizure is generalized stiffening in extension. Stiffening, similar to this disorderate or decorticate posturing associated with breathing and eyesight. It is usually associated with intraventricular hemorrhage and kernicterus. You all know that when the bilirubin goes more than certain level, it can damage the brain. That's called kernicterus. Usually, whenever there is a tonic seizure is observed, the prognosis is poor. So, myoclonic jerks movements are rapid, isolated jerks that can be generalized or multifocal or focal. Common in babies with developmental defects, including anencephaly. So, coming to the causes, it could be perinatal complications like birth asphyxia, intracranial injuries, metabolic causes like hypocalcemia or hypoglycemia, CNS infections, inborn errors of the metabolism like galactosemia or phenylketonuria. There are so many. Organic acidemias. Or it could be due to developmental defects like microcephaly, hydrocephalus, neuronal disorganization or migration, and pyridoxine dependence. There is another interesting cause where the mother was on high dose of pyridoxine for some reason, and the baby is now depending on high dose of pyridoxine in the intrauterine life. When the baby comes out, for some period it requires high dose of pyridoxine till it gets adjusted to the normal dose. If that is not supplied or supplemented, it shows a seizure. It's called pyridoxine dependency. Dyselectrolytemia. The electrolytes are abnormal, especially the sodium, either hypo or hyper. There is one more entity called benign seizure. Benign seizure means they are seizure only, but they don't harm. Benign. And promptly disappear over a period of time without any medication even. Benign neonatal sleep myoclonus. So you might have seen babies, all of a sudden jerky movements you see once in a way in babies, normal babies also. During REM, especially in deep sleep, seen in the first week, disappears by two months. Benign familial neonatal convulsions. This is autosomal dominant. Chronic seizures seen on day 3 and disappears by 2 months. There is another benign seizure called benign idiopathic fifth day seizure as it occurs approximately on the fifth day, and it is multifocal seizure, disappears spontaneously over a period of time. And we can also make out the cause of convulsion depending upon the age of the onset of the seizure. If you notice seizure on day 1, probably it is due to hypoxic ischemic encephalopathy due to birth asphyxia or brain injury like cerebral contusion, first day hypocalcemia, pyridoxine dependency. You have to suspect. Between 1 to 3 days, the probable causes intracranial hemorrhage. Hypocalcemia can also produce at this age, and another important cause is inborn errors of the metabolism. I told you phenylketonuria, galactosemia, glycogen storage disorder. There are so many conditions. Between 4th to 7th day, causes like meningitis, developmental malformations, torch infections, and of course benign neonatal seizures. And between first to 4 weeks, the causes of seizure were late onset hypocalcemia, sepsis, inborn errors of the metabolism, cerebral dysgenesis, epileptic syndromes. How to approach these neonatal seizures? History, detailed history to be taken. First, seizure details. The onset, type, interictal state, and duration of the gestation. Antenatally, was there any infection in the mother? History of premature rupture of the membrane, uh, foul smelling like is the mother diabetic, or she uh, had substance abuse like any drug abuse, addiction, and is there any fetal stress history? And intranatal history, like is there any difficult labor or instrumental delivery? So was there a local anesthesia inadvertently injected to the fetal scalp? Lignocaine can produce seizure, please remember. A resuscitation history, card pH, if it is less than 7.2, indicates that it was birth asphyxia. Postnatal feeding pattern, if feeding pattern is not correct, hypoglycemia it can happen. Type of feed, was there a fever, lethargy, poor feeding, respiratory distress, family history? Family history means if there is a seizure, family history, seizure, then so uh, what you see, in this baby, it is a seizure and requires treatment immediately. And when especially family history, so one should be become very alert to give medications early. Approach to neonatal seizures. Continued. On examination, head circumference, anterior frontonally, and sutures to be seen. If the sutures are widened, hydrocephalus probably. Anterior frontally, if it is bulging or tenting, so it is meningitis. And increased head circumference seen in hydrocephalus. If it is very less, microcephaly. Where if there is a cephalomatoma, it suggests that it is a difficult labor. If there is a fracture, that is an instrumental delivery, and brain damage may be there. Needle mark, if it is there on the scalp, it is local anesthesia might have been injected into the scalp. Midfacial anomalies suggest pituitary the pituitary gland abnormalities. Cataract, galactosemia, and galactosemia you can see petechiae in hematological problems and in infections. Organomegaly, infection and IEM. Neurocutaneous markers for the brain dysgenesis. Abnormal odor, again in inborn self-metabolism. There are so many type of odor depending upon the type of the inborn errors of the metabolism. Coming to the investigations, first and foremost is blood glucose, calcium, phosphate, magnesium, and sodium to be routinely to be done. Hemoglobin, packet cell volume, blood counts, CRP, and blood culture. If you suspect meningitis or sepsis, CSF to be drawn, so to be sent for analysis and culture. If meningitis is suspected, or any seizure, of course, to assess ultrasonography, that is cranial ultrasonography, if there is intraventricular bleed or other malformations, you can do CT scan and MRI. EEG, of course, is a must. Urine routine, serum ammonia and lactate. ABG, charge serology to be carried out. So now coming to the management. Neonatal seizure management it is an emergency. Identify the cause early, type of the seizure, characterize the seizure. Any emergency is ABCD approach, that is airway, patency, is the baby breathing, look for circulation and temperature. If the baby is continuing seizure, then first you put the baby on oxygen, secure an IV line, draw blood samples for baseline investigations like sugar, calcium, magnesium, sodium, potassium, arterial blood gas, hematocrit, sepsis screen. If the baby is hypoglycemic, that is when the blood glucose is less than 40 milligram per deciliter, administer 2 ml per kg of 10% dextrose as bolus, followed by continuous infusion of 6 to 8 grams per kg per minute. If blood sugar is normal range, sample for blood calcium should be drawn. If abnormal, that is less than 9, 2 ml per kg of calcium gluconate of 10% should be given IV under cardiac monitoring. Even with this, when the hypoglycemia, hypocalcemia is not there, or even after correcting those things, if the seizure continues, then we have to arrest the seizure by giving phenobarbital as the first line drug. 20 milligram per kg IV, start over 20 minutes, and you can repeat another 2 times 10 milligram per kg per dose till you reach 40 milligram per kg. If seizure is not controlled, then you can use phenytoin 20 milligram per kg IV slowly over 20 minutes under cardiac monitoring. You can repeat phenytoin another 10 milligram per kg dose if seizure is not controlled. If seizure continues in spite of phenobarbital maximum dose, phenytoin maximum dose, the benzodiazepams has to be tried, like lorazepam or midazolam. And still seizure continues, then consider pyridoxine dependency. Pyridoxine dependency. Wean anti-epileptic slowly to maintain only phenobarbital. Whatever the drug with which you can control the seizure, finally only phenobarbital to be continued as a maintenance drug. The dose of the phenobarbital we have already discussed. So only thing is hypotension and apnea to be looked for. The disadvantage is sedation and hypotonia. Phenytoin, that is also 20 mg per kg IV over 20 minutes. Repeat 5 mg per kg one more time. Then look for heart rate rhythm and extravasation. If there is an extravasation, so the sclerosing of the vein happens. Necrosis can occur, and the sclerosing of the vein also can happen. If you get fast phenytoin, that is preferable. It has got increased the solubility, fast infusion, and it can be given safely IM, no tissue necrosis. Pyridoxine, when you consider to give when the seizure is not controlled, when you suspect dependency, pyridoxine dependency, 50 to 100 milligram IV under EEG monitoring. Repeat one more dose, 100 milligram or 10 minutes. If the seizure is not controlled, maintenance 5 milligram per kg per day or 50 milligram day of oral dose. Adverse effects, apnea and hypotonia. The other drugs, midazolam. Midazolam, the bolus dose is 0.15 to 1.1 milligram per kg IV bolus. Then 0.5 to 1 micrograms per kg per minute infusion, and it can be increased every 2 minutes up to 18 micrograms till seizures are controlled. Lorazumab, if you consider 50 to 100 microgram per kg IV slowly. If you want to use lidocaine, 2 milligram per kg in 10 minutes, followed by IV infusion at 6 milligram per kg per hour for 6 hours. So once the seizures are controlled, then how to wean out these anticonvulsants? When all anti-epileptic drugs except phenobarbital when seizure is controlled, wean wean all the anti-epileptic drugs except phenobarbital when seizures are controlled. You might have used either phenytoin in addition to phenobarbital or benzodiazepam, pyridoxine, lignocaine, whatever. But as a maintenance dose, only phenobarbital we continue. All other drugs, are weaned off. You do or perform neurological examination prior to discharge. If neurological exam is normal, stop phenobarbital. If it is abnormal, then continue phenobarbital. In the follow-up, do a neurological examination at 1 month. If it is normal, taper over next 2 weeks. If it is abnormal, then do a EEG. If that is normal, you taper the drug over a period of 2 weeks. If abnormal, then continue phenobarbital, reassess after 3 months. Coming to the prognosis. Prognosis is excellent, 100% late hypocalcemia. In subarachnoid hemorrhage, it is 90%. In conditions like hypoxic ischemia, meningitis, hypoglycemia, early hypocalcemia, so 50% good outcome is there. And if dysgenesis is there, brain dysgenesis, then the outcome is 0. The seizures, in spite of not only one drug, even with the combination of the antiepileptics, the seizure continues, the outcome is not good. In unknown, when the cause is not known, the outcome is comparatively 75% good, and about 25% the seizure continues in spite of anti-epileptic drugs. Before I conclude, neonatal seizure is a medical emergency, and as I have already told, the neonates are at particular risk for the development of seizures because metabolic, toxic, structural, and infectious diseases are more likely to be manifested during this time than at any other period of life. If they are not detected early, intervened early, the sequelae are going to be more because it is a growing brain.